INT'L, Director of GI Clinical Trials and Precision Medicine at Northwestern University in Chicago. I am here today to talk to you about the clinical decision support tool we have developed for vedolizumab in Crohn's disease. Selecting the right treatment for the right patient at the right time is challenging. As more treatment options become available for Crohn's disease, it is important to identify patients most likely to respond to a certain therapy, so we may optimize both short and long-term outcomes. As one step in this multi-step process, we have developed the vedolizumab clinical decision support tool for Crohn's disease, a data-driven scoring system specifically for vedolizumab that predicts a patient's probability of response to treatment, offering a new opportunity for treatment personalization. Using the pivotal phase 3 patient-level clinical trial data from Gemini 2, we derived clinical predictors in a decision support tool, which was then validated in routine practice cohorts, both in the US with the Victory Consortium and internationally. Using the Gemini 2 clinical trial dataset, we identified 5 specific predictors for response to vedolizumab in Crohn's disease. These included absence of prior anti-TNF exposure, absence of prior bowel surgery, absence of prior fistulizing disease, baseline albumin, and baseline CRP. Most notably, we noted that these weren't simply measures of clearance, but true independent predictors of response to vedolizumab in Crohn's disease. These predictors were then translated into an easy-to-use clinical decision support tool with very easy calculations that can be done at bedside. That was then used to stratify patients into a low, intermediate, or high probability response for vedolizumab in Crohn's disease. The vedolizumab clinical decision support tool was then validated in a routine practice cohort of patients in the Victory Consortium, where it was observed that patients with a high probability of response to vedolizumab achieved 20 to 30% higher rates of clinical remission, steroid-free remission, mucosal healing, and deep remission, as well as steroid-free deep remission. When validated in the routine practice cohort of the Victory Consortium, we demonstrated that the tool had over 90% sensitivity for clinical, endoscopic, and durable remission, and over 80% specificity for these outcomes. Said differently, less than 8% of patients who are going to achieve remission with vedolizumab would have a score of less than 13, and less than 20% of patients who do not achieve these outcomes would have had a score of greater than 19. Since its development in 2018 from the phase 3 clinical trial program dataset and the Victory Consortium validation, there is a growing body of evidence in support of the vedolizumab clinical decision support tool for Crohn's disease. The tool is able to predict rapidity of onset and how quickly patients will respond, as well as longer-term risks for Crohn's disease-related ER visits, hospitalizations, and surgeries. Most notably, we've also shown that the tool predicts outcomes for both the IV formulation and subcutaneous formulation. Other groups have now validated the drug specificity of the vedolizumab clinical decision support tool in Crohn's disease. And in this routine practice cohort of patients treated with either vedolizumab or ustekinumab, those predicted to have a high probability of response to vedolizumab had 80% rates for steroid-free clinical remission at 1 year, compared to only 50% in those who were treated with ustekinumab. In summary, we've developed an easy-to-use clinical decision support tool which can offer Crohn's disease patients a new opportunity for personalization and decisions and determining whether vedolizumab is the right treatment for them at that time.
Welcome to IBD Academy Middle East, and welcome back to this very nice format led by Professor Ala Sharara from the American University of Beirut. And I'm sure we will learn together today again from two very interesting cases, one in Crohn's disease and one in ulcerative colitis. And the Crohn's disease case will be presented by Fatema Al-Alawi, is a consultant gastroenterologist and hepatologist and honorary president of the Crohn's Colitis Society of Bahrain. And an ulcerative colitis case will be presented by Mohammad Shebab, who is an IBD specialist, consultant gastroenterologist from Kuwait, as well as the Secretary General of the Kuwait Gastroenterology Association. So very distinguished presenters today. We are also joined by a panel that includes Dr. Elouali from the Cleveland Clinic Abu Dhabi and Dr. Sharif Mogawer from Cairo, and Dr. Ben Cohen and myself from the Cleveland Clinic will moderate this seminar. The format is as prior in that the case presenters will go through their cases with stopping points, where then I will address the panel to hear their opinion on how they would treat these complex patients. And then we will all learn together, and the ulcerative colitis case will be presented by Dr. Cohen. So with this, I will hand it over to Dr. Al-Alawi, and thank you so much for being with us.
Thank you so much. Okay, so again, good evening, everybody. It is my pleasure and honor to be amongst you tonight. Thank you so much, Dr. Ala, for the cordial invite. Now, it is an extremely difficult chore to actually concise a 2-year worth of follow-up in 20 minutes, but I'll try my best to. A couple of years back, a friend of mine spoke to me about, please continue, Nancy. Next slide, the first slide, please. Nancy, can you hear me? Nancy? Yeah, next. Okay, so a few years back, a friend asked me to review his relative. At that time, he was 30 years old, a known case of psoriasis, on adalimumab for the preceding 5 years. Now, prior to seeing me, he was seen by a different gastroenterologist because of abdominal pain and constipation around 6 months prior to seeing me. He was waved off as habitual constipation and discharged on laxatives. So when he presented to my clinic, he came in with anemia, weight loss, loss of appetite of 6 months duration. On examination, he was pale, but he wasn't jaundiced. Generally, he looked unwell. Further examination, there was no palpable lymph nodes. The abdomen was soft. There was no tenderness and no palpable masses. We ran quick tests, and the first thing that came back was a hemoglobin of 11 with low index. Next, Nancy. So that was the, okay. So would you like to discuss at this point, or shall we proceed to what we did?
I think we proceed.
Okay. So immediately we scheduled an upper and a lower GI endoscopy. The upper was unremarkable as expected, but the lower showed a diffuse, ugly-looking cecal inflammation. Malignancy could not be ruled out then and there. We were faced by an IC valve stricture that was extremely tight, impossible to negotiate in spite of changing scopes. So we just took biopsies from the Z segment and we sent him for a CT tap. The CT abdomen showed this thickened cecum and terminal ileum, no masses or strictures, and extensive peritoneal lipidopathy. Differentials of the radiologist were lymphoma, TB, and Crohn's disease.
Perhaps we pause here real quick, Dr. Al-Alawi, and let me start regarding the initial thoughts on this case with Dr. Alamil, and before we go to Dr. Elouali for the next question. So, Dr. Alamil, how would you approach this patient further, and do you agree with the differential diagnosis of the radiologist?
Yeah, so I think this is an interesting case. A young man with a history of psoriasis and presenting with this GI symptoms and the findings that Dr. Alawi described. So I would be worried about inflammatory bowel disease. We have TB common in this region of the world. So I think tuberculosis is also an important consideration. We don't see colon cancer that often in this age group, although we see younger than what is described in Western population. But definitely things like lymphoma would be in the differential diagnosis. So I think these are the main things in mind. I can't think of anything else, to be honest with you.
Mm-hmm. Could this be, do you agree with this, Dr. Elouali? And then thinking about TB and being endemic in the region, how would your workup be different from IBD?
Right, thank you, Flo. Yes, I completely agree with Turkey. Essentially, we do see a bit more TB than we see back in North America here. And you'd really want to make sure, essentially, when you're doing the colonoscopy, if you have that suspicion, just regular biopsies are not enough. And what you would want to do is to really send for tissue, essentially for PCR, for TB, and then TB culture as well. That's really a good way to actually differentiate between IBD and TB. And you'll just get extensive biopsies, really. You want to get biopsies that stricture looking thing or that mass looking thing, and you want to get a lot of biopsies so that you don't get any false or false negatives. You want to get biopsies, of course, since you're still suspecting IBD, kind of segmental in the colon as well. And then the other thing is you're going to want to get a quantiferin, a chest X-ray. If your suspicion is a little high, he's lost weight as well. So you're going to make sure that really there's no other signs of TB. So that would be essentially, my approach in terms of ruling out TB. I always, whenever I have that suspicion, of course, the quantiferin usually is positive. It doesn't have to be, though. I usually involve infectious diseases right off the bat. A lot of the times I'll give you advice as to how you should be biopsying it, what you should be doing with the samples.
Yeah, very good. So before we move on further to summarize extensive biopsies, send them for PCR, get a quantiferon, get a chest X-ray, involve infectious disease early. Let me ask Dr. Mogawer before we move on in the case. So what on colonoscopy and what on imaging would help you distinguish between this differential diagnosis, lymphoma, TB, Crohn's disease? So are there any specific endoscopic features that point you towards, for instance, TB over Crohn's disease, or anything on the CT abdomen that points you to one versus the other? So, Dr. Mogawer still on?
Yes, I'm on
perfect.
here.
Perfect.
You can hear me now?
Yes.
Yes. So I understand that strictures in this area could be confusing to a great extent, and to reach a definite diagnosis relying upon colonoscopy alone or CT or imaging alone, sometimes it would be very difficult and very confusing. What's evident in this case that there are lymph nodes, and I would like just to emphasize that not every finding on colonoscopy would be specific. Yes, the patient has anemia, has a loss of weight, has lymphadenopathy, make us going towards maybe tuberculosis, but also on the other hand, if the CT doesn't show for tuberculosis, if endoscopy I couldn't see deep ulcers, I couldn't say that this is, for example, definitely a Crohn's disease. So findings which are non-specific, I would not prefer to rely upon them only. In other words, I think that we have to take every point globally, the clinical picture, the situation of the patient, colonoscopy findings, imaging findings, but not one specific finding to rely upon on the differential diagnosis of this critical zone area. And I think all of us have read about this topic, which was published in the Red Journal, defining that there are major and minor criteria. Major criteria would lead you to diagnose a definite specific etiology, while absence of the major criteria, you can difficultly reach a definite specific diagnosis.
Yeah, so I agree completely with all the comments. So just based on colonoscopy and CT abdomen, it's very hard to discriminate. We then need biopsy culture, PCR, chest X-ray, and so on. The criteria clinically that are more frequent in TB, for instance, are these constitutional symptoms like night sweats and fevers, which you don't have in Crohn's disease that much unless you have an abscess or a phlegmon. And then ascites, for instance, being more common in TB, but perianal disease being more common in Crohn's disease. But when you look at the numbers, truly there's an overlap, and none of these findings is entirely exclusive to one versus the other. And the scoring algorithms that have been developed, or diagnostic algorithms, are also not perfect. So a really tough situation. And I'm curious, Dr. Al-Alawi, how this case will continue.
Okay, so we didn't do a chest X-ray. We did a CT tap, so a thorax, abdomen, pelvis, and the only place that showed lymphadenopathy was the abdomen. From there onwards, Nancy, can you please proceed? Yeah. So we stopped his Humira pending further investigations. And of course, nothing goes well. He started to complain of joint pains. So we referred him to rheumatology. All rheumatology workup was negative. And at that point, biopsies came back. So these are the initial results of the rheumatology workup. And as you can see, PCR of the peritoneal wash was negative at that point. I don't know why it says here on anti-TB, but he wasn't on anti-TB. Biopsy of the cecum, markedly inflamed granulation tissue, occasional small non-necrotizing granulomas. The adjacent colonic mucosa shows occasional cryptitis, expanded lamina propria by mixed inflammation. No dysplasia or malignancy seen, no specific microorganisms seen on staining, and the features were labeled as Crohn's disease. Can you proceed, Nancy, please? Proceed, yeah. Nancy? Yeah, back. Proceed now. Okay. So, shall we proceed?
Yeah,
Perhaps
we stop here and let me ask Dr. Ala Sharara, does this biopsy help us as it is? How do you interpret the granulomas? What is the sensitivity of PAS and Steele-Nielsen stain? And do you think this is Crohn's disease, or is this TB or lymphoma?
Yeah, thanks, Flo. I mean, I think the biopsy is not helpful to really clinch the diagnosis here. I mean, you could see, of course, granulomas in both diseases, unless you have a classic caseation, which might sort of suggest more tuberculosis than Crohn's disease. There's a lot of overlap. And I think the stains, the biopsies, the culture, the PCR are not all perfect, even in the diagnosis of tuberculosis. So there is a possibility of false negative in all these tests. So it doesn't really help us really one way or the other. I think both diagnoses are still, possible at this stage.
I agree with you that there is there are cues in terms of granulomas being small. It's more likely in Crohn's disease, non-necrotizing, more likely in Crohn's disease, but not obviously exclusive. Where in TB you may have more caseating, more larger confluent granulomas, but this is also not specific. And then the staining on a conventional biopsy, in fact, lacks sensitivity, exactly like you mentioned. So we are still searching for the right diagnosis. Dr. Cohen, I don't mean to put you on the spot, since I know at the Cleveland Clinic we do not see so much intestinal TB, and we're actually learning a lot today about this disorder. But what would be your next step for workup in this patient?
Yeah, I mean, it's a tough situation, and a lot does depend on clinical suspicion. So obviously it's very different how we approach here versus there, but a detailed history around possible TB exposures, family in the home, whether there's anybody maybe that they localize with that is having similar sorts of presentation or has a history of TB. In some cases, what also concerns me here is that the patient was already on adalimumab, and this all developed while they were on the anti-TNF medication, which certainly you can have Crohn's that doesn't respond to the anti-TNF, but I would want to know more about what their drug levels were. Was this progression through adequately dosed adalimumab, which may be dosed differently for psoriasis than it is for Crohn's disease? But it may be that ultimately, given the severity of the disease in the cecum, that we're talking about doing a resection, which can be more diagnostic also if we're not certain of the best course.
Yeah, and an excellent point. And I asked Dr. Al-Alawi that we continue the case, but one way to diagnose these complex cases, particularly if there's a stricture that would be a surgical indication in any way, is that surgery, in fact, then will provide the diagnosis, because it could be indicated for both TB and Crohn's disease. And we currently don't have any indication that this could be lymphoma based on the biopsy. I see Dr. Al-Sharara, you turned your camera on. You have any further comments?
No, I think Ben's point is really well made, because the particular situation that has developed in this patient, the particular circumstances, kind of makes you, more suspicious of TB. I mean, he was on adalimumab, he had weight loss, extensive adenopathy, never had really true GI symptoms, etc. But then again, that's not enough to basically clinch the diagnosis. It makes you more suspicious that something else is going on. I think the value of a laparoscopic also examination, lymph node sampling, sometimes can basically help you in trying to avoid and doing is ileocecal resection in cases where your suspicion is high for TB.
Mm-hmm. Very good points. Dr. Al-Alawi, please take us further in the case.
Okay, Nancy, next, please. Okay, so logically, we consulted pulmonary and ID, and the biopsies were negative for TBs. Quantiferon was negative twice. Sarcoid screen negative. There was no pulmonary involvement, so their decision was it's unlikely to be TB. The pictures in favor of malignancy are inflammatory bowel disease. Next. Yeah, it keeps getting better. So he started to complain of resurgence of skin plaques and worsening of peripheral joint pains. Rheumatology labeled him as psoriatic arthritis, and we were under pressure from rheumatology and dermatology to restart biologics and treat as psoriasis and Crohn's disease. Next. So after all of this, we decided to do the basic, which is a PPD test. It was labeled as negative by the treatment room nurse. And I was like, I lost hope. Everybody's saying it's Crohn's. Everybody's saying it cannot be anything else. It cannot be TB. So I just asked him, please come over. We'll measure it ourselves. And the negative reading was 17 millimeters. We had the GI-MDT following that. The other consultants were suspecting Crohn's more than anything else. And they advised to start Stelara. Now, when you get that pain in the back of your neck and you cannot do something, even when everybody else says it's the right thing to do, you cannot do it because it feels wrong. So we went and he had an extended MDT with rheumatology, ID, dermatology, and pathology. Eventually, we all decided, okay, let's withhold immunosuppression, like major immunosuppression. We can start anti-TB. Rheumatology wanted to start MTX just in case there was anything to suggest sarcoid and it might help with his joints, awaiting PCR results. And dermatology were into local therapies for his psoriasis. So next. Okay, keeps getting better and better. 3 weeks into anti-TB, he presented at emergency department with nausea, vomiting, and abdominal pain. He came in late at night. Symptoms responded partially to antiemetics. He still didn't look that well. He wanted to go home. I asked him to stay over until I see him in the morning. And when I saw him, he was still nauseous, no more vomiting, no more pain. So we ordered the CT, and there was a small bowel obstruction, significant wall thickening of the terminal ileum, and stricture with pre-stricture dilatation. So we consulted surgery, and he was taken as an emergency laparotomy. He underwent right hemicolectomy, side-to-side anastomosis, ileocolic, and intraoperatively, the surgeon was like, I had to go and do a cancer protocol because it looked so bad. There were multiple peritoneal deposits, ugly-looking omentum, thickened peritoneum, and he managed to resect a mass of around 7 by 6 centimeters. His impression was either peritoneal carcinomatosis and the patient is like end stage, or if he's lucky enough, it would be TB. Proceed or discussion?
We can proceed. Mm-hmm.
Okay, so continue. So the peritoneal wash showed many lymphocytes with few reactive mesothelial cells in a bloody background. There were no malignant cells. Ziehl-Neelsen stain for acid-fast bacilli was still pending, and the cytology was negative for malignancy. We took the whole specimen overseas because we were not happy with what was happening. And the second opinion pathologist favored Crohn's based on the specimen, based on the gross specimen. So a week later, after all of this, we had to do another CT. That was 4 weeks into the anti-TB treatment. And the peritoneal thickening was still there. Omental caking was there. This time there was no defect in the left upper quadrant with moderate amount of free fluid. Now he has ascites. And the lymph nodes were there, but they were smaller. Continue or pause?
Perhaps we hold here for one last stop, because I know you have some very nice summary slides with the literature at the end. But just to have Dr. Shebab comment, who joined us from Kuwait. So you are the consultant now on this case. Patients in the hospital. You heard all the story. What do you make of it? What are your next steps? How do you get clarity in this patient? Dr. Shebab still on? Oh, it looks like he may have dropped off. Then I would ask Dr. Kotubi from the Cleveland Clinic Abu Dhabi instead. Dr. Shebab called off for his consult, and you're replacing him. So what is your recommendation for clarity in this patient?
Thank you, Florian. Thank you, everyone, and thank you, Dr. Fatima, for a very interesting case. Now, again, there are so many things still unclear. Whether this is TB or not, we don't know. And what bothered me, what are these plaques and the omentum, and why he developed ascites? I mean, is it a malignancy? Is it carcinomatosis? I mean, the pathology is supposed to help us more than this. But again, I'm like you guys, I'm lost. I mean, I don't think this is, we don't have a clearance yet. I mean, this is TB. And my question to Dr. Fatima, why did we start anti-TB if we are not even sure this is a TB? So there are many questions which are unanswered so far. I'm interested in the pathology more, and also the finding intraoperatively are not typical for TB, are not typical for Crohn's. We do see lymphadenopathy, but what are these plaques? What are this involvement of the omentum? What is the fluid in the abdomen showed us? I mean, all of these answers, we need answers to get us a better diagnosis.
Mm-hmm. So I'm going to ask Dr. Aliwali one last question before, and thank you, Dr. Kotubi. before we close the case for time reasons. The discussion is very, very interesting. So one way to distinguish Crohn's disease from intestinal TB could be to treat and see, does the patient respond? So what's your approach to that if you treat? So you treat, is it a problem because the patient, if it's Crohn's disease, may not be an effective therapy? And then how do you follow up for response? Do you look after 2 months, 3 months, 6 months? Do you do endoscopy, fecal calprotectin? How would you do that in your practice?
Great. I'm going to talk about my practice, but honestly, I haven't had a lot of cases like that. But I can say, so let's just start off with the easy case of latent TB. In that case, once they have a quantiferin that's positive, you're going to want to at least make sure that they're on TB treatment for let's say 4 weeks. And then you can actually start them on a biologic. The important thing is that the quantiferin may never get back to normal. And so it's actually useless to follow it over time. So you kind of go clinically with exposures, with symptoms, and potentially chest x-rays. And it's kind of similar with actual TB. In terms of actual TB, you're going to want to make sure that you're really treating it first in the setting of, but if you're not sure whether this is Crohn's or TB, you treat your TB, you follow the guidelines from the advice from your ID consultant. I'm always in touch with ID here. I'm never going to make up, timelines on my own. So whenever they think is enough, or whenever they think that the course is complete, then what we can do is repeat the imaging, repeat the scope, and see what it got to before we start them on a biologic, honestly. I have to say, though, I can't wait to hear more about this case, but we gave enough specimen, the whole thing came out, right? So you should have a diagnosis. I find this mysterious that we're still not able to get to a diagnosis. I mean, you should be able to rule out TB, you should be able to rule out lymphoma once you've done surgery and if you have that specimen. So I'm just a little bit confused as to why we don't have a diagnosis yet.
It may be a purposeful cliffhanger.
Unless it's just Crohn's, exactly. So that's why I can't wait.
It's not always that easy, Dr. Sarah. After we finish this case, I'll just touch notes on another patient who was very similar. Anyway, so can you please? Okay, so now when you just need somebody to tell you, please do this, and enough thinking. So I had to consult echo experts. The first expert came back as, it's always challenging situation as a TB with onset on anti-TNF therapies, usually extrapulmonary and maybe slow to respond to anti-TB treatment. On the other hand, if his resection looks like Crohn's and all specific TB tests and quantiferon PCR is negative, I would not think too much of the PPD result. The granulomas are probably all Crohn's disease. If he's clinically unwell, I would probably, in the first instance, give him corticosteroids while continuing on anti-TB, and he should be able to resume anti-TNF for his joints once TB treatment is completed. Maybe even before that, if ID is okay with it. The second expert was like more brief. So some of the Crohn's disease can be diffuse, quite diffuse and very extensive. Given that biopsies have excluded malignancy, we would treat such patients with ustekinumab for both psoriasis and CD. Peritoneal and lymph nodes will take time to resolve. Ustekinumab has less problems regarding TB, but anti-TB treatment for 6 months concurrently may be wise, and he left it to me. So what we did. Can we go next, please, Nancy? Yeah. So post-surgery, we restarted anti-TB. We withheld MTX. Regarding his joints, rheumatology started him on NSAIDs PRN. And regarding his skin, he continued to have topical therapy. He was off immunosuppression for 6 months, so we repeated his colonoscopy. The anastomosis looked absolutely normal. Neotite deep intubation was achieved. It was unremarkable to the extent visualized. All biopsies came back as normal. CT abdomen repeated. There was complete resolution of the previously seen lymphadenopathy and inflammatory changes, with normal appearance of the bowel and the mesentery. Next, please. So we continued anti-TB for a total of 9 months, referred back to dermatology. Ustekinumab started according to derma protocol. Last time I saw him was more than a year ago. He was asymptomatic on 3-monthly Stelara. And colonoscopy and CT abdomen then were both normal. I just, for the sake of the presentation, I gave him a call, and right now he's on Cosentix. So basically nothing to do with us, and he doesn't need follow-up with gastroenterology. Just going back to your comment, Dr. Sarah, regarding diagnosis of TB. I had a very similar case last year, mid of last year. This one had pulmonary involvement. Everything done for her was negative. Bronchoscopy, lavage, PCR, AFB, repeatedly for 6 months. She was coughing her lungs out on everybody with a similar colonoscopy result, in a similar colonoscopy finding. And again, with pressure from her, she was a rheumatoid arthritis patient, or she is. And I had a lot of pressure from rheumatology to start something to cover Crohn's and rheumatoid arthritis, because everything came back as Crohn's disease. 5 months after her coughing her lungs in everybody's faces, she comes back to me and she says, doctor, you were right, I have TB. My AFB came back positive. So it's not as simple when it comes to TB, sadly enough. Anyway, we can go to the discussion or the slides. So Nancy, next, yeah. Now, we know that we gained a lot by starting biological therapy. We basically revolutionized treatment of IBD, and our patients are having a relatively very normal life now. Unfortunately, there is a downside to every good thing. So the risk of developing TB, active TB, is much higher when you're on immunosuppressives. And not only just developing active TB, reactivation of latent TB, or having a new infection with Mycobacterium tuberculosis is more frequent or higher in patients with immunosuppressives. Now, the risk varies depending on the biologic used. The highest risk, I was surprised when I read this, was with Humira, and the second was with infliximab. Next, please. So what's the data? So next, please. So there's not much there about TB in inflammatory bowel disease, because at the end of the day, all the data comes from the West, and we see it more in the East, so we have to depend on very limited resources. Now, this was a paper that shed some light on the outcomes of treatment, like if you have a patient with latent TB and you treated them before or prior to receiving biologic therapy, what would be the outcome? Would they develop TB at a later stage or no? And sadly enough, this paper came back with results that even if you treat latent TB and IBD effectively, this does not eliminate the risk of reactivation or getting a new infection. Next, please. This paper has to be very, very solid because it's from India. And again, there is a high risk of TB during therapy, even though the patients were screened prior to starting anti-TNF. Next, please. This is a UK cohort study, and as everybody mentioned in the room here, it's very difficult to actually ascertain whether a patient has latent TB or no. A lot of our patients are on steroids probably prior to getting screened. Some of them are a bit older, so they've had the BCG vaccine. Quantiferon is not always available in all centers, so it becomes a bit of a challenge. And this paper shows that it's not only just challenging to screen for latent TB, you wouldn't know who would actually develop TB while on anti-TNF in spite of good screening. Next, please. Now, this paper, I just kept it in for the sake of science, but I don't really agree with it, at least from our experience where we are. Dermatology, according to this paper, are more likely to treat their patients for latent TB than us. And I think that we screen our patients more effectively or efficiently than dermatology, but whatever. So next, please. a quick algorithm of how to tackle those patients or patient pre-anti-TNF. So patient history, past history, TB exposure, and I think whether it's I don't know whether there should be much weight on these two, because most of our patients now are educated, they're living in good standards, and none of them really would know when or how they got exposed to TB. And then there are symptoms and signs, including a chest X-ray, as Dr. Sarah mentioned earlier. And then to differentiate whether there is active TB or just latent TB. Now, in this slide, the numbers are 10 mm, 10 to 15, and 15 for PPD test. I don't know how my colleagues here follow up in their clinic, the PPD test, but would you agree with 10 mm for a patient who's immunosuppressed or a patient who would start a tumor necrosis factor, anti-tumor necrosis factor? I think it's but we go a bit lower. We go like 5 mm. So I don't know how the rest of you would think about this. Anyway, next, please.
Perhaps we
Yeah,
use the prior one as the last slide, because for the sake of time, I can hand it over to the second case. And I appreciate a lot, Dr. Al-Alawi, for bringing us this interesting story and for the great discussion to the panel. And now I hand it over to Dr. Cohen for the second case. Thank you very much.
You're welcome.
Thank you. That was a very interesting and complex case with a lot of learning points. And we're going to change things a little bit. Again, another complex case, but focusing on UC and the relationship with PSC. And we invite Dr. Shahab, who again is IBD specialist from Kuwait and the Secretary General of the Kuwait Gastroenterology Association and the head of the GI and endoscopy unit at Wara Hospital, to start with his presentation.
Pause for a minute or something. Should this? Hi everyone, good evening with those on the East, and good morning guys in the States and North America. So I'll talk today, like I'm talking about more of a management challenge case, patient with UC and PSC. Just before I start, like as an introduction, we know like PSC is strongly associated with UC, especially with ulcerative colitis. Around 60 to 80% of PSC patients have IBD, and only last like 5 to 10% of those with IBD acquire PSC. And there are some data, retrospective data, that patients with IBD PSC more likely to have pancolitis, they have to have a rectal sparing and backwash ileitis. And the risk of IBD recurrence after liver transplantation with IBD PSC is about 30%, despite being immunosuppressant therapy, which is quite high. So this is a bit challenging young patient, girl. So she's a 24-year-old female with refractory kind ulcerative colitis and post-liver transplantation for PSC. She has a past medical history of sickle cell anemia, which is quite common in the region. She had complicated, unfortunately, by bilateral avascular necrosis of the head in the childhood. She had bilateral head replacement during her childhood. She also being admitted and comes with recurrent sickle cell crisis and painful and chest crisis once or twice a year, which requiring for sure like IV fluids and recurrent blood transfusions. Regarding also her past medical history, she was admitted with community-acquired pneumonia and acute chest crisis twice in 2014 and 2018, was hospitalized for IV fluids, antibiotics, and convulsive therapy. During COVID as well, she was admitted with severe COVID pneumonia in March 21, and she was mechanically ventilated and on vasopressors, and she was quite sick, and she stayed in hospital for about a month. She also developed septic knee arthritis in 2019. However, she was only treated conservatively with IV antibiotic, did not require surgery. She also had a secondary hemochromatosis due to recurrent transfusion, and that was by testing and liver biopsy. We'll talk about that later. So regarding her UC history, she presented initially with chronic abdominal pain and blood diarrhea in February 2019. She was diagnosed to have moderately ulcerative colitis, extensive colitis at the age of 20. At that time, her fecal calpro was 832, CRP 28, and hemoglobin 82, but that's what kind of her baseline with sickle cell disease. Albumin 38 and biopsies were consistent with ulcerative colitis. So she was started initially in mesalamine 4.8 gram per day, high dose. She had some clinical improvement of her bloody of her diarrhea, but she just continued to have like 1 blood motions per day, despite being in high dose mesalamine. Her fecal calpro dropped to like 444, CRP 19. And a repeat colonoscopy 6 months later was showing extensive, you can see this was ugly, Mayo 3 extensive colitis. All stool workup, including C difficile, and CMV and all were normal. And at that time, she had a biologic workup done, and the decision was she need to be started on a biologic.
Do you want to pause right here and see
Sure.
from the panel sort of how they may approach? So maybe we can start with Dr. Malgauer. You're seeing, obviously, this is a severe presentation. You see the endoscopic pictures here. What would you be thinking about in terms of medical management of this patient? Dr. Malgauer, are you still on with us?
Oh yeah, I'm sorry, I was muted. So I just want to thank you again. But it looks like a quite severe case of ulcerative colitis. And of course, in such a case, I think that we should start our start my video. Okay. So I think that we should start aggressively with medical treatment, but I'm a little bit confused about one point. Was this form of severe ulcerative colitis, which was described initially in the history as a refractory ulcerative colitis, was it developed after the transplantation, or was this before she was undergoing transplantation? Can you just clarify this point, please?
No, we didn't come to the process. This was like a 1-sentence summary for the case.
Yeah.
But at this point, we didn't have any transplantation yet.
Okay. So at this point, I will be thinking of the biological therapy. And of course, after excluding and doing the workup of the biological therapy, I think infliximab or Humira would be the first choices in anti-TNF. On the other hand, also, I would consider Vida to be a good option or a good choice, provided that we don't have any evidence of extracolonic manifestations in such a case. So it's to start biologics with preferably starting on anti-TNF.
And then maybe we can go to Dr. Al-Alawi. Any other thoughts on how you would classify this person's disease severity? Are there any features that are particularly concerning to you from the endoscopy? And at what point do you even involve surgeons in the care of these patients?
Yeah, such a great point. Thank you, Ben. I mean, looking at the pictures at first, I thought, is this actually Crohn's? You do see very deep ulcers, a lot of cobblestoning. But whatever this is, it's really severe. And agree that I would have the surgeons not too far. I think at this point, she's having 1 bowel movement per day. Her CRP is still high, though her calpro is still high, but clinically, she's not doing super badly so far. So I would just hold off on the surgical consult, but knowing that, you talk about it with the patient and you tell them that this may happen in the nearish future. But she hasn't had yet a trial of biologic. The first thing I would do, though, I actually was confused as well, just like Sharif. I thought she already had a liver transplant and it was already immunosuppressed. So I was also thinking we definitely have to rule out CMV. I would still rule out CMV in this case and make sure to ask for it specifically, because a lot of pathologists won't do that unless you ask for it specifically. And once you've ruled out your CMV, I would really start her on a biologic ASAP. And my first step would probably be infliximab or vedolizumab as well.
Great. So yeah, I agree completely. Whenever I see the deep ulcerations, that's always a concerning sign. If it is UC, then the risk of needing surgery is very high. And I usually, even if I don't have them see the surgeon right away, I do present surgery as an option just to introduce the concept, because that may be the most effective treatment at some point for the patient. All right, Dr. Shahab, you can take us through what happens next.
Yes, so CMP was negative like many times, and CDF was negative. So because of her like immune suppression, she has recurrent infections and so on. And so the team were worried. She wasn't my patient at that time, but she was worried about infection. So the preferable choice was discussed with the patient. They agreed on vedolizumab as a safer baby options for her. It's not moving. Okay. So she started on Vido, and she received the induction doses, and she also received the week 10 dose of vedolizumab. She also got a prednisone course of 40 milligram and tapered. She improved initially, but once her steroid were less than 20 milligram per day, she started again to have blood in her stool and diarrhea. Around 6 months later, her fecal cal was still high, 555 CRP was still high. And the colonoscopy, so it's still like Mayo 3 pancolitis, was maybe a bit better than the pictures we saw. However, at that time, her liver enzyme was elevated, started having, as you can see, ST45, ALT41, ALP, and GT was elevated. And all chronic liver disease workup was negative. And she had a liver biopsy, we know, like was suggested maybe PSC, but secondary hemochromatosis was seen, no, and a sickle cell cholangiopathy, which can also be seen in this patient. She had an MRCP, which was very suggestive of ERCP, of PSC, and then was confirmed by, and then PSC was confirmed by ERCP as well. She was then seen by our hepatologist and was starting also uric acid. Regarding her UC, also was discussed the second options, as she failed vedolizumab, was it ustekinumab or anti-TNF, and again at the discussion, and then was beginning of COVID. So the decision was to start to switch her on ustekinumab. So this was March 2020, like maybe a month after COVID. So she was starting ustekinumab, 390 IV, then followed by 90 every 8 weeks. 12 weeks later, she was still having diarrhea, occasional occasional bloody stools. Her fecal cal was 356, CRP 19, stool workup inclusive was negative. So her dose was escalated to every 4 weeks. So she received 1 IV ustekinumab, and then a 90 at 8 weeks, and then 90 at 12, and then every 4 weeks thereafter. At week 24, she was in clinical remission. She didn't have blood in the stool. Her CRP was 11, fecal cal 311, and she was doing well. So she didn't want to have a colonoscopy, and she was having well, but however, CRP was repeated again, fecal cal. She never went like in a full biochemical, I would say, remission until maybe was colonoscopy repeated 12 months later, which showed still like maybe the right side of the colon healed a bit. It was maybe Mayo 1, but however, the left side was still severe bad Mayo 3 colitis. So in March 2021, like around the same time, she was admitted to ICU, as I mentioned at the beginning, with severe COVID pneumonia. She was very sick. She had a very tough stay in the hospital, and then she was discharged home. On discharge, she resumed they resumed her physician on ustekinumab every 4 weeks. However, after taking 2 doses of ustekinumab, she again developed diarrhea, abdominal cramps. Her CRP was 24, fecal cal was 555, stool C. diff, and also other was negative. And her liver enzymes was going also higher despite being an ortho. She was started on prednisone, and then ustekinumab was stopped, and she was started on infliximab monotherapy because of her immune system. We want to be in combination therapy, the risk of infection, and with proactive TDM. At week 24, she continued to have diarrhea despite like high dose of infliximab. Her infliximab level was 15, and there were no antibodies. And at the same time, she was admitted twice with cholangitis, October and December 2021. The extensive septic workup and imaging were done, and a repeat ERCP was showed that showed that she had CBD is colonized with Pseudomonas, causing recurrent cholangitis. At that time, the MDT meeting happened, and her infliximab was discontinued, and she was planned to have a liver transplantation because of recurrent cholangitis. She received IV antibiotics for the cholangitis, and If she has a prolonged fever, like difficult to control when she's off IV, and then she was on oral antibiotics. And at that time, she was 23 years old. So there was a decision, like big decision with her family and the surgeons about should we, when we do liver transplant, should we do colectomy at the same time? There was extensive counseling, a benefit risk. Initially, the patient was willing to have colectomy plus liver transplantation. And we didn't have that program at that time, the liver transplantation. She received steroid to control her symptoms. She went to the UK, to London, to have her liver transplantation. Again, she had the MDT there, and then at the end, they decided, and she also decided not to have a colectomy at her age. She maybe was worried about pregnancy, and then the decision was to leave her colon, and she had a liver transplantation. So she did a liver transplantation in March 22 with no post-operative complication from her liver stand view. These are her post-op medication after liver transplantation: tacrolimus, apixaban, also deoxycyclic acid, folic acid, azithromycin, and prednisone 10 milligram daily. And also she was post-operatively, she was started on ustekinumab. I'm not sure why ustekinumab. Anyway, she was started there. IV, then again induction and then Q4 weekly, and she came back home like four weeks later. In April 2020, she started flaring up again with three bloody diarrhea, 3 to 4 bloody diarrheas per day. Colonoscopy showed again pancolitis with Mayo endoscopic score of 3. Stool work including C. diff, CMV were negative. Her CRP was 15, fecal calpro 657. So this is just to summarize the timeline. So UC diagnosed in 2019 on 5-SA, then she started on vedolizumab. In 2022, ustekinumab was escalated to Q4, still flared, then was switched to infliximab monotherapy. In December 2020, it was decision to have a transplantation, liver transplant. She had liver transplant in 2022, and April 2022 flared again on ustekinumab post-liver transplantation.
And just to clarify again, the decision not to have the colectomy with the transplant was driven by the patient, not by the multidisciplinary team?
I think both, like the surgeons and the patient. That's what I like from the reports what they get.
Okay. So maybe we can go to Dr. Khatoubi first, and what I would ask you is, obviously, this is a very challenging case, and when you're approached with somebody with severe disease like this that may be hesitant to undergo colectomy for different reasons, how do you approach those conversations? And then after that, I'll go to Professor Sharara for maybe your thoughts on what you would do medically next steps, given where we're at with the patient. So Dr. Khatoubi, how do you approach the discussions around surgery?
Thank you, Ben. Well, when we do have sometimes these kind of very, very difficult cases where we have to sit together with the patient and the family, and we put in fact, actually, she already failed 3 biological treatments. So what's next? It's either she can be on steroids and can be dependent on it in the future, which is a very bad idea, especially if she's if she gets a transplant. But I would push for surgery. Now, looking at the long term for this patient, being on all this immunosuppressive medication from the transplant standpoint, in addition to having very complicated and very inflamed colon, and what is her risk of coming into malignancy in the future, based on all of this. So we usually have a very, serious discussion with the family. The question we ask ourselves, what else we have in our hand? The only thing left is the JAK inhibitors, and I don't think whether this is an option in her case or not. But again, I would push very seriously taking the whole history with the patient for surgery. I don't think this patient, again, I have a kid 14 years of age, exactly similar condition, passed already 3 biologics, and we're looking for the future. And the patient's father asked me the question, what's his chance of getting cancer? So again, so many immune suppressive medications, so many biologics, how much his immune system can take before actually a malignancy can appear. So I would have a very serious discussion with the family regarding having surgery.
Yeah, and you know, some of the concerns that sometimes come up with surgery in patients with end-stage liver disease and portal hypertension, if that's developed. I know it's a bit different when we're doing it for strictures and cholangitis with PSC, but you know, the concerns around surgery there are that you can develop varices at the stoma and the high risk of pouchitis with those patients. So, you know, the options are not always great, but in the case where they're going to get transplanted, you know, we're less concerned about at least the stoma varices piece of it. But Dr. Sharara, so now the patient's been transplanted, they're on immune suppression, and they're still having severe colitis symptoms. So what's your approach here?
I would tend to agree with Zahid. I think this is a pretty tough situation. Your options are limited. She has failed multiple agents. You know, adding any additional immunosuppression, especially of a general nature, such as JAK inhibitors on top of, you know, her tacrolimus and immune suppression would be pretty high risk. And I think a discussion about surgery should be done. I think the options are limited. I'd be interested to see what Muhammad did with this patient to see how she progressed.
So in the interest of time, maybe Dr. Shahab, you can take us to what happened next with the patient.
Yes. So like I was like searching the literature what to do with her, like because as you mentioned, like JAK inhibitors, I don't think it will be a good option with her like infection and like thrombosis before. So I come across like vancomycin was and John Hopkins was done, and what about vancomycin in those patients with UC and PSC, and like Alan Sharabati group in Hopkins, they tried it. So immediately I called Aline and said, did you like watch this about vancomycin and UC and IB and PSC? And she said, yes, we have like we have a couple of cases and it works well. We don't know what's the mechanism of action, but it does. So this is the study that they published. It was a single center retrospective data, 8 patients with an IBD clinic who were taken oral vancomycin. Those patients had average disease of 15 years old and 5 had liver transplantation. And patients who have failed or partially responded to mesalamine immunomodulator or biologics, and they were on vancomycin 125 PQID, like as the dose for C. diff, and then lowered to the least effective dose 125 TID or BD. And there is an improvement just of the effective time in the Mayo score, endoscopic Mayo score, and the duration of the follow-up was 9 to 36 months. And their patient will maintain an endoscopic clinical remission. Also, there are some case report, one of the colleagues in Riyadh, Dr. Bawadri, and also another colleagues that for those patients with oral vancomycin, UC, and PSC. So I discussed it the patient that, and before going to the patient, though, there is also in children, there was 2 open label RCTs for PSC and IBD, but those for the PSC itself. And giving oral vancomycin for PSC, and this giving oral vancomycin, actually the primary outcome was decrease in GT-ALP, ALT from the baseline, and around 30 patients were enrolled, and 29 additional patients also requested to be involved, around 60 patients, and the majority of these patients with oral vancomycin, interestingly, their GT-ALP, ALT improved or normalized. The majority of them normalized with vancomycin. And in this study, the patient with all of them like well-tolerated oral vancomycin for their liver enzymes. So I talk about the patient that listen, there are these options, the colectomy, and she didn't want to do colectomy, so there is an antibiotics. We give it for C. diff, but we're going to give it now for something for PSUC. There are some like some small study, the case series that it's worked, but I'm not sure. So we did start her on oral vancomycin, had difficulty with pharmacy to convince them without a diagnosis of C. diff to give the vancomycin. And anyway, so actually she did extremely well with vancomycin. There was no blood in the stool, no abdominal cramps. At week 12, she achieved like was a clinical remission. We didn't have it for years. Her CRB came down to 5, fecal cal 124. 6 months later, she was extremely well. She said, like, I never, in Arabic we say that ما شفت العافية من سنين, the word that she was describing. يعني she felt very well, but she didn't want to have a colonoscopy because she had a lot of them. I said, okay, we can wait a couple of months later. So remember the first colonoscopy you saw, this is like, we have a colonoscopy in between. I don't have the images, but this is the last colonoscopy this is a year ago, which was perfectly normal. And I'm also like amazed, like this is my first case. I'm not sure how does vancomycin do. There is like a lot of literature about the microbiome with patients with UC and PSC, and probably something to do with the microbiome. Anyway, she did very well. And however, her transplant hepatologist didn't like vancomycin much because it's interact with the TACRO levels, and they don't have a good trough level of the TACRO because of vancomycin. So they was discussing if we can reduce the dose. So then we reduced the vanco to BID, but she started having diarrheas, like 3 to 4 times diarrhea. So her biochemically, she was doing well, but she didn't like that she having diarrhea. She said, I want to go back to 3 times a day. Then she was back on 3 times a day. And currently she doesn't want to, like, difficult now to convince her to stop the vancomycin or to give her any other medication because all other breast medication did not work. Anyway, now because of her recurrent sickle crisis, that now they're deciding her hematologist to do bone marrow transplant. And she is going to Riyadh in Saudi Arabia to do a bone marrow transplant this summer. So the question would come back to me, like, how long am I going to keep her on vancomycin? I'm not sure. And then when she goes for bone marrow transplant, she's going to get other immune suppression therapy. And then what other options we can do. And I think also now at this time she's doing well. It's also difficult now to say to do a colectomy. And that's it. Thank you.
Wow.
It's hard to believe those pictures are from the same patient.
Really?
But yeah, amazing case. And I've seen very similar things with vancomycin in PSC patients, and I'm using it as a first-line therapy. I know we've had an IBD Live, which is presented at Cleveland Clinic. We've seen a number of similar types of cases with these dramatic responses in PSC patients, and we don't completely understand why. I guess, Dr. Sharara, would you dare take the patient off vancomycin?
No, absolutely not. Honestly, this is an incredible response. I mean, it is as good as vancomycin in C. diff, even better. I mean, the mechanism of action kind of intrigues me because even with microbiome, hypotheses, I mean, vancomycin is not this particularly broad acting. So you're talking about a specific effect, that really is restricted to some bug. I mean, even if you go back to the C. diff days before discovery, initially it was thought it was Staph aureus because they had response to vancomycin and treatments, and they weren't really sure what the organism was. So they thought it was staph until they discovered Clostridium and then labeled it Clostridium difficile. So really amazing case, wonderful results. And I think one interesting thing is that with a transplant, you may reset her immune system, and then possibly you can try to get her off her vancomycin.
Yeah, possibly.
The bone marrow transplant, I mean.
Yeah.
Mohammed, I think it's fascinating. I actually have a case that is exactly a mirror of your case. Exactly the same patient, secondary hemochromatosis, except it wasn't sickle cell, it was thalassemia. Everything else was exactly the same, and she did amazing on Vanco as well. And I actually never ended up stopping it. She just would refuse, obviously. That's the only thing that made her feel better. But just to be clear, I had continued her ustekinumab at every 4 weeks and then went into endoscopic remission on the Vanco. But what I did is I tapered it off to the minimal, dose that was effective. So at some point she was up to, I think, once every other day. And really, when you think about it, it's basically not absorbed, and it's a very safe medication, except for those obviously interactions with TACRO. But if you're able to get through this, I would just keep her on it. I don't see a disadvantage in stopping it or in continuing it.
Yep, I agree. And when I've used it, I've also used it in combination with other immunosuppressive, usually these severe patients, JAK inhibitors with the oral Vanco. And there is some, I think, case reports about JAK inhibitors in transplant patients and even modifying the immune suppression around the transplant for the patients that are JAK inhibitors or on JAK inhibitors. So it may be worth a conversation with the hepatologist in terms of that. Well, we're over time as always with great discussions around these complex cases, and it's really wonderful to connect with everybody around the world through IBD Academy, and we appreciate the participation of all the board members and your insight, and we look forward to the next conference in a few months. So on behalf of Dr. Reeder and myself, thank you for allowing us to participate. Dr. Sharara for leading the way with this great conference.
Thank you to the speakers, moderators, to the attendees. Really great session. Looking forward to our next one on June 12th. I want to thank everybody, and I want to also thank Takeda for supporting this educational activity today. Thank you, and really best of luck to all. See you soon.
Thank you.
Thank
Bye-bye.
you. See you.
Thank you.
Hello, I'm Parmveer Delai, Director of GI Clinical Trials and Precision Medicine at Northwestern University in Chicago. I am here today to talk to you about the clinical decision support tool we have developed for vedolizumab in Crohn's disease. Selecting the right treatment for the right patient at the right time is challenging. As more treatment options become available for Crohn's disease, it is important to identify patients most likely to respond to a certain therapy, so we may optimize both short and long-term outcomes. As one step in this multi-step process, we have developed the vedolizumab clinical decision support tool for Crohn's disease, a data-driven scoring system specifically for vedolizumab that predicts a patient's probability of response to treatment, offering a new opportunity for treatment personalization. Using the pivotal phase 3 patient-level clinical trial data from Gemini 2, we derived clinical predictors in a decision support tool, which was then validated in routine practice cohorts both in the US with the Victory Consortium and internationally. Using the Gemini 2 clinical trial dataset, we identified 5 specific predictors for response to vedolizumab in Crohn's disease. These included absence of prior anti-TNF exposure, absence of prior bowel surgery, absence of prior fistulizing disease, baseline albumin, and baseline CRP. Most notably, we noted that these weren't simply measures of clearance, but true independent predictors of response to vedolizumab in Crohn's disease. These predictors were then translated into an easy-to-use clinical decision support tool with very easy calculations that can be done at bedside. That was then used to stratify patients into a low, intermediate, or high probability response for vedolizumab in Crohn's disease. The vedolizumab clinical decision support tool was then validated in a routine practice cohort of patients in the Victory Consortium, where it was observed that patients with a high probability of response to vedolizumab achieved 20 to 30% higher rates of clinical remission, steroid-free remission, mucosal healing, and deep remission, as well as steroid-free deep remission. When validated in the routine practice cohort of the Victory Consortium, we demonstrated that the tool had over 90% sensitivity for clinical, endoscopic, and durable remission, and over 80% specificity for these outcomes. Said differently, less than 8% of patients who are going to achieve remission with vedolizumab would have a score of less than 13, and less than 20% of patients who do not achieve these outcomes would have had a score of greater than 19. Since its development in 2018 from the phase 3 clinical trial program dataset and the Victory Consortium validation, there is a growing body of evidence in support of the vedolizumab clinical decision support tool for Crohn's disease. The tool is able to predict rapidity of onset and how quickly patients will respond, as well as longer-term risks for Crohn's disease-related ER visits, hospitalizations, and surgeries. Most notably, we've also shown that the tool predicts outcomes for both the IV formulation and subcutaneous formulation. Other groups have now validated the drug specificity of the vedolizumab clinical decision support tool in Crohn's disease. And in this routine practice cohort of patients treated with either vedolizumab or ustekinumab, those predicted to have a high probability of response to vedolizumab had 80% rates for steroid-free clinical remission at 1 year, compared to only 50% in those who were treated with ustekinumab. In summary, we've developed an easy-to-use clinical decision support tool which can offer Crohn's disease patients a new opportunity for personalization and decisions and determining whether vedolizumab is the right treatment for them at that time.